Good morning. I'm Nancy Glass from the School of Nursing, and it's a real pleasure to be here today, and congratulations to the Hopkins Fogarty Center for this great symposium we're going to have. I'm excited to introduce the next session, Session 2. It is on policy, politics, and health research ethics. And we do have an excellent lineup of speakers. So we have 4 speakers for this session. And we have 90 minutes, so we're going to get started quickly. And I'll start with introducing our first speaker, Lynn. So I'll call him Lynn because we've been in places together. So this is Lynn. I want to introduce Leonard Rubenstein. He's the director of programs on human rights, health, and conflict for the Center for Public Health and Human Rights. He's also the past executive director of Physicians for Human Rights, and he does some really interesting and challenging work, and I am glad to introduce him to talk on human rights consideration and health research in Africa. Lynn?
Thank you, Nancy, and it's really a delight and a privilege to be speaking with you today. And beyond that, the fields of bioethics and human rights have a history and a well-deserved reputation of talking past each other. It's a real never the twain shall meet kind of situation, except that's not true at the Berman Institute, where human rights is part of the whole interdisciplinary approach. And in fact, although we had no conversation, I feel like Ruth actually was my setup. Because questions of human rights and questions of justice are really the same. And in a way, that shouldn't be surprising. When you think about the origins of human rights and the origins of bioethics, in 1947, we had the Nuremberg Code coming out of the Nazi experience, which was really the fount of bioethics in the post-war world. And 1 year after that came the Universal Declaration of Human Rights, also out of the Nazi experience. So they shouldn't have been separated. And they're both based on respect for autonomy, beneficence, all grounded in human dignity. But I want to talk about human rights bringing a different kind of dimension to the kinds of questions we're going to be talking about today. And I'll review 4 cases. But before I do, I want to give you 3 minutes on human rights. I want to tell you first what I mean by human rights. People use human rights as sets of values, like in the Universal Declaration about how we treat each other. But I'm using it in a more human rights community sense. And that is that there are specific obligations governments undertake through international treaties to bind themselves to behave in certain ways. We can call that law. Whether it's legally enforceable is a different question, but these are specific obligations, and my whole talk will be about the obligations of government. And those obligations are of 3 kinds. One is that governments must respect rights. And that's what we usually think of human rights. They shouldn't interfere with free speech. They shouldn't torture. They shouldn't engage in arbitrary arrest. They shouldn't punish people arbitrarily. They shouldn't discriminate. They should respect property rights. They shouldn't deny health care. So that's what we mean by respect. But they have another obligation called protect. And that is to prevent people from having their rights infringed by the actions of third parties. And that applies to everything from regulating pollution and tobacco to many other dimensions of life, including discrimination and inequalities. Because part of the obligation of human rights, because of its special concern with vulnerable people, is to redress some of the power imbalances that are reinforced by social practices. And that's why states, governments have an obligation, for example, to outlaw discrimination in employment or housing or other spheres of life. And that obligation to protect is central, I think, to the research ethics mission. The third obligation is to fulfill, provide health services, to provide education, to provide for human needs, something the rest of the world understands. In the United States, we don't understand it so much. But that is the third obligation. And in all three of these realms, what is unique about human rights as compared to ethics is there is accountability. There are formal accountability mechanisms at the global level, and in many, many places at the national level, and there should be. So accountability is critical. So let me start with the kind of pure model and tell you how I think human rights kind of fits in, okay? All right, here's your pure model. Okay, you have the researcher and the subject, and the researcher has obligations to the subject. That's what research ethics is about. Very straightforward, and human rights certainly agrees with that. Well, in order to make sure the researcher behaves in an appropriate way, we have a research ethics committee to interact with the researcher to make sure the person or the institution behaves in a way that respects the person. And as Ruth and Nancy talked about, in reviewing research ethics proposals, we have to be concerned about the place people occupy in society. That is, if people don't have access to health care, if they're subjected to cultural practices that deprive them of their decision-making power. All these social determinants have been incorporated into the research ethics business, just as they are incorporated into human rights. Now we have another element. When we introduce human rights, there's another player up there. It doesn't have to be up there, but it tends to be up there because it makes the laws and it controls things. So we have the state. This is a dimension we don't usually think about in bioethics, but is central to human rights for the reason I said that human rights is about states undertaking obligations to their people. So we have to look at how the state interacts. Well, one thing the state is supposed to do is to make sure that people aren't exploited. It's supposed to make sure people are respected. It's supposed to make sure that it doesn't engage in actions that interfere with free choice, all those things. Now, let's see how this can play out. These green, if you're colorblind, it's the thick arrows. The state can have an impact. This seems very abstract, but we'll get concrete in a minute. It can have a huge impact on social determinants. It can, for example, address inequalities through legislation and all kinds of ways. On the other hand, it can oppress. It can make social determinants worse by depriving people of their speech. It can also interact with the subject directly. We know that. Free speech is a perfect example. And it can also have relationships with the researcher and with the Research Ethics Committee itself. For example, it can provide requirements for the Research Ethics Committee's activities. As I said, this is abstract, but we'll get to some concrete examples in a moment. Okay, so here the moment has come that you've been waiting for. I'm going to give you 4 cases, and I should say that these all come from Africa, but just as Nancy and others have talked about, there's many, many other places in the world, including the United States, where these kinds of questions should arise. This case comes from my own experience, in fact, with my friend Nancy Glass. We're doing a project to try to develop a tool to identify women and girls who were subjected to gender-based violence. Because these women in refugees and displaced persons settings, there was partnership with the High Commissioner for Refugees. The problem is these individuals are often not identified because it's too difficult to come forward, and how can you develop a process to identify people without putting them at risk? So the idea was we will develop a screening tool, a few questions that everybody gets asked. Well, that was the project. In accordance with our traditional rules of research here at Hopkins, we had to get permission not only from our institutional review board here, but from the Ethiopian equivalent, because it's a local, the research was being done in Ethiopia, also done in Colombia, but we needed that permission. Well, there's a little background about Ethiopia. I don't know anybody, if people are here from Ethiopia, but it is not, you might say, the freest country. It has a very fine record in health, but it violates fundamental freedoms. In 2009, the background of this IRB application, in 2009, it adopted a law prohibiting civil society organizations and NGOs from engaging in activities, foreign NGOs and civil society organizations from engaging in activities pertaining to human rights, gender rights, children's rights, disability rights, citizens' rights, conflict resolution, or democratic government. Any civil society organization or NGO that received more than 10% of its funding from foreign sources was deemed a foreign organization and couldn't engage in any of those activities. You can see what kind of government does that. The law actually forced the closure of the major gender rights organization, the Ethiopian Women's Lawyers Association, which had a domestic violence hotline. They didn't want gender violence reported. So that's kind of the context of our application. So what did they say? They said, we're very happy for you to come to Ethiopia and do this study, mostly with Somali refugees. But they said, in our formative research where we were finding about their experience of gender-based violence, we do not want you to publish your qualitative findings. You can publish anything you want about your instrument, but you can't publish your findings about qualitative work. Now, I should tell you, by the end, and I'm not going to tell you this story, by the end, that restriction was lifted. But what was going on here? Well, they were, first of all, the state was preventing women who experienced gender-based violence from getting help by forcing the closure of the hotline. They had a relationship with the social determinants by preventing information from getting out. I should tell you, the reason that dotted line is for people who are colorblind, and it's also, there's a glow, there's a glow and a dotted line. I think it's relevant. There isn't one on the subject because these were refugee women, and they really didn't have a direct relationship with the state. So I was giving the state the benefit of the doubt there because they were refugees as opposed to citizens. And of course, the state was impacting the Research Ethics Committee in terms of what information it would suppress from us. So that was the pathway. So here we have a human rights violation which wasn't even related to the study per se, that was having an impact on the conduct of the ethics committee and our ability to reveal information. So the answer to that has to be to hold the government to account, to say that these violations are human rights violations, they impact research, and they are unacceptable. Let's go to case 2. This is Uganda. We know Uganda criminalizes homosexuality, and the situation there is very bleak. My colleagues are doing research there on HIV/AIDS. As many of you know, men who have sex with men are highly vulnerable to HIV transmission, and because of the laws, they are underground, and there's risks of prosecution, and even outreach workers are targeted. So at the same time, research into the needs of this population and the dynamics of transmission and prevention strategies and all the things we would want to know about how to stop transmission of and treat HIV, that's essential. And the local MSM community wants to participate in this research because they feel like it's extremely important to their health and their rights. They shouldn't be excluded from the benefits of knowledge about HIV/AIDS. So, but because of the attitudes and laws in Uganda, basically the Research Ethics Committee said, we don't do this. We don't do this. This is not an acceptable study because it violates our cultural norms. Well, this is where this goes back to the first era of ethics that Nancy talked about. Human rights does not accept that cultural norms can trump people's human rights. But so we see that the government was using the ethics committee to kind of squelch the study. And the way these kinds of cases have worked out has been a workaround. That is, there are local community-based ethics review committees, and these have been set up in Burma and other countries where the ethics committee is under the control of the government and is prohibited from approving studies that the government might not like. And that workaround has been successful. And the studies have gone forward, although it's very risky. It's risky for the subjects, it's risky for the researchers, but people are very courageous because they care. But the problem is the workaround doesn't solve the human rights problem. And only accountability will get us to those answers. Now, the third case, before I get to the third case, let's add another player. Remember my first slide, it was so nice, it was just two circles. It's starting to get busy up here. It's got corporate sponsors now, are in the picture, who have a different kind of power. Remember I think I said that human rights is in some respects about dealing with power imbalances in society. So here we have a powerful player. And what is that going to do, and what are the human rights implications? So let me take a study. This is, now it's beyond my knowledge. My next two examples are about clinical trials. We know many clinical trials take place in Africa, and we heard earlier about some of the issues about clinical trials, that is, about what kind of consent there should be, what are the obligations to provide treatment after the study. These are all key human rights issues. But we also have the problem that in Kenya and as many other places, people don't have access to health care, and there's really desperate needs there. And there are also issues about the hierarchy of the medical community and the power of doctors to be coercive, cultural limitations on consent, and there have been many reports of abuses. And the problem is that we have impact. The social determinants are having a huge impact on the process. Here, the subjects themselves may be subjected to discrimination or exclusion. But the real problem is up in the review committee, where they lack capacity, they lack authority, they lack staff. And that's not just an issue of management, but it becomes a human rights issue. That here we we're moving from obligations to respect, which were the first two cases, respect human rights. Here is to protect, that there is a responsibility on the state to empower the review authority to assure that the subjects are not manipulated through these clinical trials. Then another clinical trial case comes from South Africa. And this is also an interesting problem because we were talking before about placebos. First of all, there's a lot of research that goes on in Africa that is not for the African market. And in South Africa, there's a huge amount of research that goes on for drugs that are designed for sale and marketing in the United States and Europe. And there's a case of an asthma drug, which, now I'm getting beyond my knowledge on this, but I'm telling you what some reports have said, so we're not making any accusations. I won't name any companies, but that it's not infrequent for a pharmaceutical company to make adjustments to its drugs when the patent is about to expire so that it can repatent it and sell it at a higher price, and it won't be a generic drug. So it's really a marketing strategy. It's a corporate attempt to keep its profits high. And what's happened in Africa is they've done tests in South Africa with asthma drugs with placebos. Now, we know placebos are necessary when there's no treatment, indicated treatment. But if there is an indicated treatment, there are severe ethical issues with using when you have an indicated treatment that works. And yet, what's going on is there's a lot of money at stake. And there's a lot of power in these corporate sponsors. And so what's the human rights issue when you have corporate power? We have the problem of inequality and lack of access to health care. But really, we have corporate power. And my contention would be that it's the responsibility of the government to intervene to protect people from those kinds of studies. And once again, we can't just go to the researchers because the researchers are the corporate sponsors themselves, and they've set up a whole network, and they're really in control. And so we need kind of a regulatory scheme that will enable that kind of control and redress of the power imbalances to take place. So those are 4 quick examples. You can imagine how there are many, many other circumstances. But I just will conclude by saying that this kind of gets at some of the questions that Ruth raised about justice, because human rights is really about justice as well. And it also provides a window into what steps can be taken to identify responsibility for the actions and to hold those entities accountable. I hope we have further discussion, but thank you very much.
All right, we go way back, Lynn and I. So, thank you, Lynn. That was great. We are going to hold the questions to the end, where we'll invite all the participants up and we'll have a round of questions. So next, I know this is a very timely topic we're going to discuss now, a national response to the ethics dimensions of Ebola. So let me introduce Aminu Yakubu from Nigeria. He is the Senior Health Research Officer at the National Health Research Ethics Committee, the Federal Ministry of Health in Nigeria. And I got to tell you, I think I'm funny, so I'm going to tell you the story. So I arrived back from East Africa, South Africa last week, and I was stopped and interviewed by Immigrations and Customs, and they said, which of these countries have you been to an Ebola country? And I said, yes. And they said, which one? And I said, the United States of America. And he didn't think I was as funny as I thought I was. So I'm really glad to have an expert here to provide us with detailed information.
Thank you very much, Professor Glass. I'm going to take back that expert part. And it's really a pleasure to be back here. 5 years ago, I was here with Nancy and Adnan. And my presence here is actually a reflection of their tutelage in those years. And we get to see Professor Faden, but very now and then. Because as Adnan rightfully said, she's really a very busy person doing a lot of work. So my presentation, I'm just going to share with us some issues, the mechanism that was adopted to control Ebola in Nigeria, and then at the end highlight some of the ethical issues in the process. Okay. So how it all started, and this is something that we all knew about. But after the index case arrived in Lagos, really the issues started with perhaps the index case not coming forward to immediately say, look, I really had contact with people that had Ebola. Perhaps if he had done that at the first, probably we wouldn't have had the number of cases we had subsequently. But then the rest is history. So that's Nigeria, as we all know. And those are the key 3 states that were affected, mostly Lagos and Rivers State. There were some fears about outbreak in Enugu State, but luckily they didn't turn out to be positive. So there were about 25 people that were followed up through the incubation period of 21 days, and there was no case. So really the cases were mainly in Lagos and Rivers State. So in total, there were 19 confirmed cases and 1 probable case, and 13 of them were linked to the first index case, and then we had 3 second-generation and 3 third-generation cases. And finally, 8 deaths in total. So really 7 that were confirmed. The 8th one is the probable case that eventually died, and it was after the death, and so there wasn't really able to confirm the disease until after the person had passed away. So what was the national response? It started really with immediately on, shortly after the death of the first index case, President declared it as a national emergency and constituted a presidential interministerial committee to really look into the case and ensure that appropriate communication is implemented, because they didn't want to allow any room for rumors, and they didn't want to allow room for people to get scared. And they really wanted people to get the right messages, that they need to protect themselves, and that if they were ever in contact with any potential case, that they needed to report, and that really access to healthcare services were the best option, other than probably resorting to traditional medicine and a number of things. So they wanted to make sure that the right messages reaches the people. So there was the establishment then of the EOC, which is the Emergency Operations Center. Initially, that was just in Lagos State, but when there was an outbreak in Rivers State, a similar kind of mirror image of that system was put in place in Rivers State. And then, obviously, there's the leadership and support from the governments and the commissioners of health of the affected states, which are Lagos State, Rivers, and Enugu. And these were really important, because if you understand the political economy of Nigeria, states are like autonomous, just like the United States, if you would like. They're autonomous, and the states can decide what they want to do in their own setting. Unless you have the commitment and support of the governments in those states, it will be very difficult to really get things done. But having the governors take leadership and then having the commissioners of health also rally around all the resources in the states and getting healthcare volunteers to come forward to really join the fight was very important. So that's definitely not clear, but at the top of it was really the leadership of the minister. He said, well, this is a fight that we need to win, and the minister has to be on top of it. So that was really important. So there were the EOC, that's really the structure of the EOC, but they had like these 6 major units that they set up to kind of help in the process. There's the epidemiology and surveillance, case management and infection control, the social mobilization, lab services, point of entry, which are the airports and the land crossing borders and the seaports, and also management and coordination. So EPID and surveillance. So under that, they had the alert, investigation, and response, the contact tracing and monitoring, and logistics and general coordination, and operational research. Now, the operations research was very central, very important, because they needed to go into the communities to find out what were the rumors going on in the communities. How are they able to kind of really counter those rumors to make sure that people don't panic and begin to stigmatize others unnecessarily? Because this is, again, important. For example, somebody has malaria, and he has fever, and they needed to have people understand that somebody with malaria is not the same as somebody that has Ebola. And we needed to really have that understanding among the community members and also the healthcare facility workers. And then also operations research among the healthcare facilities around, because they wanted to look into the future. Initially, when they began to see that the cases were really, or at least the number of contacts, were really increasing in geometric fashion, they really wanted to make sure that should, in case this decides to really continue to go geometrically, we need to make sure that there are healthcare facilities that we can send people to. There are healthcare facilities that can provide services to these people. And one of the ways to do that is really to begin to do needs assessment of surrounding healthcare facilities to see what they have on ground and what resources they might need if there was ever a need for them to be used as isolation centers, if you would like. So that's the epidemiology curve, and those are the dates. So you have the confirmed cases, the suspected cases, and the probable cases. I'm not going to bother us with that. And that's the geographical distribution by local government areas. You could see Port Harcourt had a total of just 4 cases. And then you have all the others are in Lagos State. Those are just different local government areas in Lagos State. So contact tracing. A total of 894 cases were followed up, and they decided to use what the mHealth thing, which is the use of Android phones to use to register and monitor all the contacts. And all contacts that develop symptoms automatically trigger messages and alerts to the team, as well as case management team for immediate flow. So there was usually in all the EOCs like a dashboard through which when the contact tracers go out and there's a contact, they send an alert and it goes to the dashboard, so they're able to monitor these contacts real time. And all the contacts were followed up for 21 days before they were certified Ebola free, and that is usually done by lab testing. So that's a flow diagram of cases and contacts. So when a contact is identified, I hope I can use this. Yep. Yeah, so this is the flow really. Contact identified, and then they visit the contact. If the contact has fever or has no fever, they continue to come back and continue visiting the contact. When there's a fever, information case management, the contact is handed over to the information case management team, and they begin to do clinical assessment and really go through the process, as it were, till the end. Sorry. So the data management, all the data was managed using APInfo. There was data harmonization between initial Excel and APInfo databases, and that's still ongoing because of some failures in ICT in using the APInfo real time. So they had to really have a backup on Excel, and they're really now doing the final harmonization. This is not to say that all the contacts have not been followed up, but just to have really that data cleaned up and harmonized. The e-reporting system via the Android phones is linked to the AP info, and that's really where you get the real-time messages coming in. And that was what helped to improve data. And this is what they were doing at the points of entry, and that's a picture, them screening somebody at the airport. And there were standard operating procedures and flow charts that the public health staff were using to do that. They weren't really just working from the blues. And they now also established secondary isolation or secondary screening areas for anybody that is found to have abnormally high temperatures. So those are taken to a more isolated place where some level of clinical assessment is done to be able to ascertain whether this is something we really need to be worried about and send to the Ebola centers, or maybe it's something, maybe malaria or something like that, and that they could just handle that without having to quarantine the person. And the lab services, in total, we had 4 laboratories in Lagos, in Ogun State, Edo State, and a mobile lab provided by the EU, which initially was stationed in Enugu State, but when there was nothing to be scared about any longer in Enugu State, that was moved over to Rivers State. So those were what were used to confirm cases, and when cases have finished, follow up, to confirm cases and cases that have been successfully treated, to also confirm that they are cleared or they are Ebola-free. And this is the case management section. This was important because at the time of the outbreak, we really weren't prepared with isolation. We really did not have standard isolation words, if you would like. During the outbreak of avian influenza, there were efforts to really put these in place. However, soon after the avian influenza outbreak was over, some of those structures were really converted for use into some other things. And this is what brings about the issue of sustainability. And people are now aware that when you have these things, you cannot just altogether go ahead and just convert them into other things. You need to have a plan for sustainability. So there was a 40-bed hospital in Lagos, another 10-bed hospital in Lagos, and when there was an outbreak in Rivers State, they had a 40-bed capacity hospital. And it was critical because also understanding how to set up the isolation facilities was very important. And the WHO and the Medicine Sans Frontiers were really critical in helping them to design them, those standards, in a way that you don't have cross-contamination. You don't have people that have confirmed disease transferring the disease to those that are only suspected, and like that. So that was the old. You can imagine what you will get inside here when you enter, and that was the old facility. But this is the new facility, and they provided this garden where people could really come out and have some fresh air and go back when there's need to get back to the facility. So the case management statistics, average duration of stay is 11.8 days, average age of patients. So they're almost middle age or something like that. Then the time interval between onset of symptoms and admission into ETC was 5.8 days. So this is inside the new isolation ward, and they were providing this chlorine for people to wash hands whenever they're going into or whenever they're coming out. This is another very important aspect of the management, which is the social mobilization, which they needed to go into the communities. They need to create awareness among both the communities and the healthcare workers. So they had mass media, they had house-to-house mobilization and sensitization, and they also had mass gatherings. So they were also going to mass gatherings and to use opportunity to say, give us some 5 minutes, and they use that as an opportunity to create awareness. These were some of the things they were doing. So you can see them at a mass gathering there, creating awareness. This is in a school where they were teaching children how to wash hands with chlorine water, and the other pictures there. And this is just a little bit more about social mobilization, but there was this dedicated helpline and internet portals that were also provided. Um, the this Ebola alert, there was also a Twitter handle. I wonder where that Twitter handle was, because that was really very important, because it also helped to really send a lot of messages out there and clarify, because initially there were a lot of issues that people were raising. People kind of raising false information that perhaps the system was not ready to handle the situation in the country. So that Ebola alert handle was able to kind of provide a platform for dialogue, especially with Nigerians in diaspora, which they get to have their information, I don't know where from, but a lot of instances, the first thing you get from Nigerians in diaspora is really critique of the system, whether it's working or not, without necessarily having first-hand information. So that Twitter handle was really important in kind of clarifying what is really on the ground. So what were the ethical issues? So the first one we identified, and this is what I was sharing with Nancy yesterday, was inadequate protection for healthcare workers. And the first I heard about that, so I was also hearing rumors that doctors were running away from facilities. I really didn't have any first-hand information until I was invited to co-facilitate ethics training for what we call the Nigerian Field Epidemiology and Laboratory Training Program that is supported by the CDC. And a CDC staff that is working for the NFLTIP was telling me his experience. He had just come back from Lagos. And I was actually also a little bit scared of shaking him, because I knew he was just out there. And there would be very little PPEs at the time, if you would like, the personal protective equipment. But he was telling me that he had this experience, and he's really worried that unless we're able to mobilize healthcare workers quickly, that this thing might probably get out of hand. And the experience was this, that he saw a nurse in an ambulance sit, and she was really just crying in that ambulance. And he asked what was wrong, and she told him that, well, my boss wants to kill me because he has sent me to go and pick up an index case. So that's really worrisome, because a healthcare worker ideally is a person that expected to have understood that this is an infection, have understood that there are mechanisms of preventing him or herself from that infection. And but even if that is understood, for example, you need PPEs, and not just the PPEs, but you need to understand how to properly put on those personal protective equipment and take them off after you finish using them and all that stuff. So I think she wasn't really provided with all these things. So the healthcare workers at the time were seeing, when assigned to handle an Ebola case, it's really a death certificate. So that was really worrisome. So that questions the obligations of healthcare workers to really provide services, even when they have not been provided themselves with the tools they need to prevent themselves from getting infected. Should they really then go out and provide services under that situation? There was also the poor state of the isolation facilities. So at the time, it was also an issue of dignity for those that are infected. So you have a 5-bedroom flat somewhere with AC everywhere, and then you're brought to, you recall the old isolation facility. And how do you really want to do that? It's also something that also impacts on the ability of even the healthcare workers to provide the services they need, because the PPEs are very hot in and of themselves, and without proper ventilation and conditioning of the environment, they are unable really to attend to the patients for as long as they would want to do that. Then there are also beliefs. Some people think about spiritual deliverance. I could go to the imam or the pastor in the synagogue or in the church to pray for us, and we could get well, or maybe using traditional medicine and herbs. There were a number of people claiming that they had some herbs that could provide cure, if you'd like. And there was also an issue of incentive. So as a healthcare worker, even if I do decide to go and provide services, I am putting myself in in an additional risk. What is that I need to incentivize me? In my own circles, what I was initially thinking is that perhaps this is an opportunity to provide life insurance, if you would like, for any healthcare worker that volunteers to say, I'm going out to do this. Because in the event that the person actually contracts the disease, also considering the fact that in some of the facilities, the care provided is suboptimal, there is a risk that the person might die from the disease. What then does he get for that sacrifice, or does she get from that sacrifice? What happens to their families after the healthcare worker passes away, and things like that. So one other thing we had in Nigeria was really looking at the triangulation of the response to Ebola, was the establishment of the treatment research group. And that was established to advise government on research into treatments and prevention for Ebola. This was co-chaired by the Director Generals of the two leading research institutes, the Nigerian Institute for Medical Research and the Nigerian Institute for Pharmaceutical Research and Development. So these were the two key people that were chairing it. And what they did at first was really to conduct some critical analysis, critical synthesis of the information and literature out there of the potential experimental treatments and for the potential vaccines that the country could consider in using to strengthen the Ebola response. This led to the formal support for trials of NIH vaccines between the Honorable Minister and Dr. Frieden of CDC, and also consideration for trials on the Canadian vaccine and the Chinese vaccines. And subsequently, they also held a high-level meeting in October to really continue to discuss these and take this forward. Ethical statement on the use of experimental drugs. There was an initial rancor and misinformation on the use of experimental drugs, and especially when we had the issue of availability of ZMapp after the first US case. And then there was also issue about the nano-silver particles. And I believe some of you must have heard about it, because actually there was more discourse around either the appropriateness or otherwise of the use of nano-silver particles on Twitter than it was really, if you would like, among the people, the common people on the roads, because they probably didn't know anything about nano-silver particles. So there was that misinformation and misconception, and in order to really clarify these things, the National Health Research Ethics Committee looked back into our local guidelines and issued a statement locally and internationally to say this is what is ethical for us in Nigeria, that if you have something that the global community, scientific community believes has some promise, we could use that without having to go through ethics committee approval, but you must have mechanism in place to document the benefits or otherwise of that, so that you could possibly consider taking it in the future into for research purposes. So that's really the statement. Innovative or non-validated medical treatment, which is treatment that is designed solely for the benefit of the patient, but in which the ability of the treatment to provide the desired result is to some degree not proven. Such activities are exempt, while recommending that they should be subjected to research in order to generate information about their efficacy as soon as possible. So I had mentioned that statement provide cover for use of such treatments without the need for prior ethics review. Also waive requirement for material transfer agreement, but it required detailed observational data documentation to facilitate future research. And shortly afterwards, the WHO statement that kind of adds more international acceptance, if you would like, to this statement was also issued. But the ethics of conducting trials still remains a topic of discussion. But basically what we're saying is when it's time to do trials in Nigeria, they will be reviewed appropriately. But there are debates in the international fora as to whether you should do randomization or you shouldn't. But the issue about community engagement, if you would like, we had written something around that saying that the international committee has already decided to do vaccines and it will be really healthcare workers that will be involved. But our question was, Did you ever consult the healthcare workers to see really whether they are willing to participate in these clinical trials? You have already decided. And we were also saying that perhaps the healthcare workers are also among the privileged. What about people living in Ebola endemic communities? What do you do with them? Aren't they also entitled to having access to these vaccines? So really them also being part of the people you consider to participate in the research, these are ethical issues that need to be considered by the international community as they try to support clinical trials in these settings. So lessons learned. Stewardship is important. Partnership and collaboration is important. And this is between government, the development partners in the countries, the non-governmental institutions in the countries. These are important for building trust and also leveraging resources. We all understand that most of the African countries affected by the Ebola epidemic really have resource challenges. This kind of partnership and collaboration helps to leverage the limited resources across board for the betterment of the people. And then the social mobilization and awareness creation was very, very important too. It helped to build community trust and support, and also raised high level of awareness and for personal hygiene and protection practices among the people. Acknowledgements. Thank you.
Thank you so much. So we have two speakers for the next topic. And this is a topic we're going to kind of loop back to where we started with Lynn, and looking at really the global rising tide of state-sanctioned homophobia. Certainly we see it in our own country here, but and certainly during the Olympics in Russia. But we're going to focus a bit on two countries in Africa today, Uganda and Zambia. And I'm going to ask our first colleague, Robert Ssekubugu, thank you, is a senior health research officer, it's the head of research programs at the Rakai Health Science Program, Uganda Virus Research Institute in Uganda, and we're very pleased to have him speak.
Thanks, Nancy, for the generous introduction. At break time, I was actually telling Nancy, sometimes when I'm going to talk about this topic, I feel like I'm vulnerable population. And she said, you're protected. So thank you. I was asked to give some comments on legislation around LGBT in Africa. And I'll try to lean so much on Uganda, and the slides you see displayed up there will not even move because they are not my slides. I want to first raise a contextual issue. So we are dealing with an issue that largely rotates around, for lack of a better word, leadership, pride, or arrogancy. And that is an issue that has taken us into serious public health troubles. In 2007, the Human Rights Watch developed or put up a very detailed report about harassment of particularly men having sex with men in Uganda, and warned the government and leadership about implications, including health implications or public health implications particularly. In general, around 2000 and forward, this discussion has been going on. In 2009, a parliamentarian brought to Parliament a private member bill that was rejected at that time due to, minor and political donor influence. But so the relationship between particularly that legislator and the global world became a little hostile. Last year, the other year, the Speaker of Parliament, who I respect very much, one of the very successful female legislator, speaker, successful lawyer, went for a meeting in Canada. And while there, I think she wasn't really treated well because of the discussions that were going on in Parliament around this bill. So when she came back to Entebbe, she found groups of people waiting for her. They were very excited. They gave her a hero's welcome. And she promised to that group that at the next Christmas, I'll deliver you a present. And that was the genesis of the legislation that later became controversial. So how does legislation come to life? How do policies come? And are these rational situations? So that's why, for lack of a good word, I said that leaders of the well and leaders of the not so well get into these disagreements, and like the saying it goes, the elephants definitely, when they fight, the grass suffers. So that's what happens in Africa around this legislation. I don't think that there is a problem with this legislation to begin with, but I think the spirit in which it comes, the level of engagement and the understanding and the level of consultation is the real big problem. What are the implications? There are already some colonial laws around sodomy, indecency, or indecent sexual behaviors that have been around since the 50s, or almost all over Africa. Some of them really have very punitive, very, very strict penalties. They are not enforced. The worry with the current legislations is the probability that they will be enforced. In fact, someone was sharing with me a map about the legislations on LGBT or indecency and sodomy in Africa. It's only South Africa that has a protective legislation. The rest of the country quite a number of countries have punitive penalties around here, around those legislations. So throughout 2000, there has been a fire, and it's now erupting like a volcano around this season for good and bad reasons. But this has very strong public health and healthcare implications. Development partners in general are the major machines for HIV care in sub-Saharan Africa. Oh, I hope there's no one from Botswana. There are certainly some people from Botswana, but some outlier. But development partners are the major machines. And the implication of this legislation, because people are fighting for who drives events on this continent or in the world, were not very pleasant. At the foot of this legislation, for example, in Uganda, quite a number of development partners withdrew resources, financial resources, technical manpower resources, for specialized skills, people who were called back home to, come back to a safe haven. And it is estimated that World Bank, Norway, Sweden combined, within the first month, they withdrew or diverted over 110 million US dollars from the healthcare system alone. I don't know if you can attach a value to that. People in this room might be talking in terms of very big monies, but the PEPFAR budget for Uganda, the last time I knew, was about 350 to 400 US dollars. So about a third of such an important fund was withdrawn from the healthcare system. So that wasn't very pleasant, certainly. We also had other implications that were not necessarily financial. For instance, we've been trying out different models to deliver HIV/TB care in Uganda. And one of the things that we are working well was to provide specialized clinics at a center. Quite a number of providers of HIV care had these specialized clinics for mothers, pregnant mothers. They need a different form of counseling. For LGBT members, they need a different form of counseling and care system and support. So these specialized clinics could no longer exist because they are going to be a source of increased stigma, but it was also very risky to see you attending that kind of risk. It had legal implications beyond stigma or anything. Around early April, one of the health facilities that was very known for providing specialized health care and venturing into complex research was raided by police. I'm sure you heard about that. And there are so many stories around why that raid happened. But the official statement was that these health providers were training people in acts in sexual acts that are non-acceptable in society. So I am yet to see or to learn about a health provider who wakes up in the morning and their job is to try and induct people into, it's a bit dehumanizing to the profession and the individuals. But that is really the official statement that we received. But my thinking is that the specialized clinics, the reason they are specialized clinics is because they do special forms of things to support their clients, one way or the other. So, but because it was a Makerere University Walter Reed project, it received global media attention. But it was not the only one that, wound up or merged. TASO had a very nice model for people like those ones. Quite a number of groups were doing that, and they ended up collapsing these clinics, and that was not effective in providing the important care to these vulnerable people. The HIV prevalence among particularly men having sex with men in Uganda is between 15 to 20%. It staggers a lot depending on who is reporting. For us to be effective with the HIV prevention programs, we must do a good job with care programs. Here was a situation where facilities were raided, wound up, merged, or in one way or another made it fairly inconvenient for the target population to access. A number of their clients left the country to Rwanda, to Kenya, to Europe, and some of them are here. We don't know if they have been able to get into the healthcare systems where they went. And if they haven't been able to get into the healthcare systems where they went, which is the most likely case, then we are not doing a job with suppressing viral load, keeping people on ART, etc., and also resistance issues. So people who have been on medication now don't access medication. They are in hiding squared. They have always been in hiding. This is hiding squared. If you've been running 7 kilometers, now you know how many kilometers you have to run. So there are HIV care implications around this legislation, or healthcare implications around this legislation. Public health research was also affected. In our IRB, we amended one important study. In fact, in 2009, before this legislation, another important study had reported, because, like I told you, the legislation comes from a context. It has a background. Its clients, its participants had reported harassment. And if you are working on a study and you are known that people who walk into this facility, men having sex with men or LGBT generally, you are actually exposing your participants to a risk. So this study wound up. They could not even raise the sample size because the loss to follow-up was growing at a faster rate. So we are going to miss responding to important public health questions in this area. And Caroline, my friend here, calls it elephant in the room, and she says it's a pink elephant in the room. So just for emphasis, it's not only an elephant in the room, it's even pink. So when people go into a hiding, we might think that they are not present, but it's a pink elephant in the room. So we have amended studies. We have, there's another important study that we asked proactively to stop administering certain modules. And it's not because the government has influence on these IRBs too much. It's because IRBs have to make sure that studies are legal. And one might ask, are you sure? Aren't you conducting studies with commercial sex workers? Or, well, it also depends, because IRBs have to assess the risk. So the level of energy that goes into harassing a commercial sex worker is not the same. So IRBs are forced. So, for example, if you administer these questions that will help you identify these men and women, yet you have reporting obligations, are the participants protected? Are you, as the investigator, protected? Is the institution protected? We indicated in the discussions we had in the week, that IRBs are a machinery of institutions. So they have to make sure institutions survive in a way or the other. So there is a lot of funding troubles these days, with, especially from development partners. I don't have the moral right or the strength to say that it is because of this. But in Africa, and particularly in Uganda, we think that we are persecuted because the Western world is being reactive, etc., etc. But I want to end by saying that all the decisions we make about these legislations, depending on which level where you are, they affect very innocent, unconcerned people. A typical Ugandan, like my wife, has been told that someone from the West is looking for your son to recruit them into acts of sodomy. And then the husband comes back after 2 days and say, someone in the West has made a decision not to provide HIV care to people to the level that is required. So an ordinary Ugandan is confused. So what's going on with these people? What's going on generally? They are recruiting people and then they are fighting that the people are recruited. So what exactly is happening? So there is a lot of misinformation and misuse of right information. There's a lot of rage and impatience and what I call leadership arrogance. Because when the elephants are fighting, I know some elephants in Africa that never purchase a Panadol in Africa. Their children deliver from Cologne, etc. So that is the type of elephant that will need to be punished at the cost of 35 million Ugandans. There's a lot of emotion, impatience, and things like that, moreover, among leaders, and that comes down to the local people. So I think we shall benefit more from the discussion later, but I know that many Africans here have, many people in the room have opinions about LGBT and legislation. Thank you very much.
Thank you very much, Robert. Let me just, I failed to mention as we started that Robert so kindly agreed to step in at the last minute when Dr. Nelson Ssekubugu could not join us today. So we really want to thank Robert for stepping in and doing such a fine job. So our last speaker for this panel is Dr. Gershom Chongwe. Sorry. He is the Vice Chair and the National Health Research Ethics Committee in Zambia. So I'd like to invite you to join us.
Yeah, I think what I'm about to say is something that has already been discussed by my previous speakers. They've mentioned many of the things that I'm going to discuss, but so I'll be short so that we give time to discussion. Just to begin, I'll begin with a disclaimer. We've been asked to come up with a policy on a policy to guide research ethics committees in the country on how to do research on LGBT or people who practice homosexuality. And because the discussions are still ongoing, these are my views rather than the views of my committee. We are not yet done with the consultations. And so, just a brief background. Most of you, I'm sure you know this, but I'll just say that Zambia is a large country, mostly Christian, with 95% people who say they practice some sort of Christianity. We just celebrated 50 years of independence, or you might, if you want to put it another way, 50 years since we kicked out the British from our country. So, just an overview of the law. We have a law which governs homosexuality in Zambia, and it falls under Chapter 87 of the Penal Code. And under that chapter, we have Section 155 to 158, which cover what are known as unnatural offenses. And under these unnatural offenses, that is where what the law calls sodomy falls. And under this law, sodomy is punishable by about 14 years in prison. And the law is actually couched in such words as having canon knowledge against the order of nature, and indecent behavior, and so on. So just to say that the law was adopted from British law because Zambia was a colony of the British. And so in the 1930s, we adopted their laws, the British Penal Code. But the British have since repealed this law which deals with sodomy, and they repealed it in 1967. But for our law, for our case, actually it was stiffened. I think it used to be a minimum of 5 years previously. Now it is a minimum of 14 years, but it can go as much as 25 years. Now, so in this environment, we also have a law which governs health research in Zambia. And this law was only enacted last year, and it's called the National Health Research Act of 2013. And under this law, apart from giving the mandate to the National Health Research Authority to regulate health-related research in Zambia, this law also allows us as a National Health Research Board to register and accredit IRBs, and also give them guidelines and so on. So it is under that law where we fall, and all these activities that we are doing are regulated by this. And must say that before this, Zambia did not have a law to govern health research at all until this law was enacted. So, I already said that the country is about 95% Christian. So we have an environment where there are both religious and political objections to homosexuality. And in this regard, I think it's very difficult as a Zambian to even begin to differentiate where the religious objections and the cultural objections stop and lie, because they are intertwined. But just to say that it is more described as morally and culturally unacceptable, and these moral objections to homosexuality are not actually to the same extent as we have in, say, the objections to prostitution or to drug use. So I think people object to homosexuality to a much larger extent than they object to prostitution. And then we have political objections. I cannot remember of any Zambian politician who has expressed support for LGBT rights. And that largely comes from the fact that we have a very conservative electorate. And just a few years ago, someone was arrested just after making a TV broadcast. The police were waiting for him just outside the TV station because they went on TV, and a local TV station, and they were talking about LGBT rights, and they were arrested immediately after the broadcast. And the charge was they were inciting the public to take part in indecent acts. And just to say that, of course, the case was thrown out by a magistrate who stated that the individual was actually within his rights under the Constitution to make whatever comments he was making. But at the time that this man was being arrested, actually a government minister made a statement to the effect that those who are advocating for these rights should, to use his own words, go to hell, and that according to the government, these acts were intolerable. So that's just describes, I wanted to give you this so that you understand the environment under which we have to come up with these guidelines. So, like my previous speakers have stated, HIV rates are much higher in, for example, men who have sex with men. The only study that I could come across was by Zulu, and it states that about 33% of men who have sex with men are actually HIV positive. And the same study found that about 50% of those individuals also had female partners. And this is the 33% should be compared with the 14% in the general population. So rates are more than twice the rate in the general population. And so we cannot easily, as public health professionals, cannot ignore this subgroup. We have a duty to treat them and treat them equally despite our personal views. And this duty also extends to conducting research. But apart from that, we know that historically stigma and discrimination has sort of hindered progress in research and tackling the HIV pandemic, because previously a lot of people died without seeking care because they couldn't just bring themselves to go to the hospital because of the stigma and discrimination. So the same is now happening to this group of vulnerable people. So our role, I see our role as an ethics committee, as we have a duty to make sure that research takes place. But unfortunately, ethics committees have been refusing in Zambia to approve research in anything to do with homosexuality. And their main reason has been the fact that there are issues to do with protection of participants from harm versus breaking the law. This is an illegal activity, so how are you going to protect participants? And the other thing is also the researchers are not protected, because if anyone is arrested, the researchers may be compelled to disclose this privileged information, and withholding information is a crime. So, and of course, there are strategies like you can forgo written informed consent, anonymize everything, and so on. But this goes away when you have a legal obligation to report a crime. My understanding so far is that as far as this act is concerned, there is no obligation to report unless that information changes. But there's no obligation to report this crime of homosexuality under our law. So at least that's something. So the question that we keep asking ourselves as we're coming up with this policy is, how do we promote or how does an IRB promote research in the LGBT community without incurring the wrath of the community? And equally, how will the researchers do this without falling foul of the community? And we are still working on this policy. We treat carefully and make sure we engage all the stakeholders. But we think that community engagement is one of the ways. If we do it properly, we probably stand a better chance of getting the right results. I put this up as some of the things that we need. In Arabic, as we write our policy, that as an Arabic looks at research or reviews research, these are some of the things that they might have to look at and address and make sure that the researcher has addressed or substantially addressed these issues before maybe a proposal is approved. But like I said earlier, this is a work in progress. We haven't yet finished discussing this, but I just wanted to share this after I was asked to talk about this subject. Thank you.
So could I invite our speakers to the front here? We're almost to 12:30, but we're gonna ask if we could just have a few minutes, because I think people probably have some questions they would like to ask. This has been a pretty important conversation we're having here, and so if speakers would come up, we're gonna take 3 questions. Yes. Yes. Okay, as you know, there's a microphone here to ask questions. If I could invite the first question. Oh, yes, sir. Yep.
Thank you. My name is Ron Gray. I'm from Johns Hopkins. I have 2 questions. One, is it, with respect to Ebola, is it ethical to conduct vaccine research if there is no evidence of ongoing transmission? And the second question is with respect to LGBT issues in Uganda and Zambia and in fact in Nigeria. Why do you think the Ugandan law received so much attention when in many other countries there are similar punitive laws? Thank you.
The first question related to the vaccine, Ebola.
Okay, thank you very much. I dare say that's a very difficult question for me to answer. However, we understand the principles of conducting research, which is that you have to do research within a community that stands to benefit from that. So I would say for as long as there's a community for which we are not yet sure that Ebola is no longer an issue, there might be an argument from one perspective to say, well, Ebola will continue to be an issue, if you would like. Nigeria has been declared Ebola-free, but we still share the same border with Liberia and Guinea, and it's easy for people to walk down into Nigeria with the virus from those countries. And there are actually Nigerians living in those countries, and one of the fears we have now is during the ember seasons that people would definitely come back home, and it is very possible you might have one person or the other come in with the disease. So the basic thing is for the research to be conducted within a community that stands to benefit from the intervention, And then secondly, we understand that it's important to ensure that there's a balance of the burdens and the risks of the study. Currently, my understanding is these trials are to be conducted in Liberia. I am not sure there is a current plan to do the vaccine trial in Nigeria now that there is no outbreak. So these things are still under discussion, but the current plans are really to do these things in the countries where the virus is still raging.
I will try and attempt to give my own opinion about why the Ugandan law received a little more attention or more attention. And Ron, this is just my thought. So I think if you have your children at home, or if you are a professor, there are students you expect to do certain things. And if they don't do those things, you get disappointed. But it's normal for regular students. And I might really be wrong. I think that, generally speaking, Uganda has been a darling to many development partners in a more special way. And has received some favors and has received some responsibilities that puts it at a better position. It's the hub of the peacekeeping force of the UN. That means that is trust, that is resources flowing into the country. ETC, it has been exemplary in production of science, in so many things. So I think that this child has disappointed the parents, and the parents, they have to strike a little harder than the regular child, because the regular child is expected to do certain things anyway, which we don't expect from this child we've been grooming over time. Like I indicated earlier, that Cameroon, Mrs. Clinton, and my president have had telephone conversations privately talking about the bill when it first came in 2009. And at that time, the president reassured them that, don't worry, my signature is the final, let them talk. So they talked, and things didn't go so far. So I think this level of disappointment of a situation where the signature was not meant to be appended from a darling, but eventually it got appended from nowhere, was such a disappointment, and you know, that received a lot of media coverage and a lot of generally that's what I think. But you know, that question is very disturbing, Ron.
Thank you.
Hi, my name is Rachel Witter. I'm a clinical nurse at Johns Hopkins, and I am a clinical faculty member at Notre Dame of Maryland. I have a question about the Ebola discussion. What is your perspective on the ethical implications of healthcare worker-specific isolation wards and care? Should or is there a difference between the standards of care or resources available to healthcare worker who becomes sick with Ebola?
Thank you, Rachel, for that question. And so what we have discussed, and we've written this in our paper, is that healthcare workers, when not provided with the tools they need to protect themselves, and with the tools they need to provide the adequate care that the Ebola patients would require, would no longer be held under professional obligation if you would like to provide that care. But they could go ahead and provide the care under humanitarian grounds. Because the risk to their health, it's something that is very important if you would like. And we looked around the different codes of ethics for medical practice. And none of those codes, including that of the American physicians, if I'm correct, and the that from the World Medical Association, made a provision that healthcare workers themselves need some protection, if you'd like. So this is really an important gap in the regulations, that the public health ethics has always concentrated on the role of the healthcare workers to provide care for the patients, but really not looking strictly or overall on the needs of the healthcare workers themselves to provide that adequate care that they need to provide, if you like.
Any follow-up to that question? Okay, is there a third question? Yes.
Good afternoon, Anand Bhan from India. Just maybe linking it to the discussion in the first session in the morning, I want to focus on the issue of leadership in bioethics in Africa. And I think one of the challenge was not particularly with Nigeria, but with the Francophone countries, was the fact that there was a lack of bioethics capacity. And in many of the earlier meetings which WHO organized, the working group that they set up, one of the huge criticisms that they faced was there was hardly any criticism, there was hardly any representation from West Africa. And the standard response was there's hardly anyone out there in the Francophone part of Africa who can be a lead in bioethics. So I think the challenge also, again, links back to this whole issue of how do we instill leadership, which is domestic, but also people who can really link in these issues back to their health systems and provide inputs when there are global needs. When there was clearly a global need, but there was hardly any presence there. And so you had to import people from other places to talk about issues which were very local and yet at the same time global, right? And so if I extend that argument to then the LGBTQ discussion, then the question would become, if we want to take this discussion forward in terms of leadership, do we then really need to engage with LGBTQ advocates in those countries and ensure either they get some inputs on bioethics issues or we encourage them to also become bioethics scholars if they're interested? And should then we have a more proactive policy when we identify future scholars for Fogarty programs to also ensure that those kind of communities get represented in the scholars that we choose, so that discussions tomorrow are informed by their personal experiences, and yet at the same time they are able to offer leadership when they go back to their countries and raise these important questions.
Lynn, I think you wanted to respond to that. That was a complex, lots of components to that. Do it.
I think those are really important linkages, Dr. Ban. But it's really going to be something very challenging to really consider, isn't it? Especially when the law bans public declaration of your affiliation with LGBTs. So how do you then get LGBT advocates to come and tell the government that they are what? So this is really something that would really need to be looked into very closely if we don't want to start getting people into jail and things like that. So it's probably something that needs more critical thinking about. But it's important, and I think it's one of the ways that when done very well could probably bring this to the fore, especially for the importance of making sure that there are healthcare services that address the health needs of this group.
Well, certainly Fogarty should be encouraged to fund more diverse scholars and train in research. But there's a larger issue on the LGBT question, and it reminds me of what Gershom said about the burdens on him and his ethics committee to deal with these issues. I think that is the way we think of these questions, that the burden falls on the ethics committee to resolve these very difficult problems that are beyond their scope. And I think we have to change our focus. We have to say that there's another place you look for solutions, and it's very convenient to say the ethics committee has to resolve the hostility in the communities and the need for research. But it should be at a different level. The demand should be on the government to respect the human rights of LGBT people and make it possible for research to be conducted. Now, that's not easy, but until that kind of demand is made, there's just going to be a lot of work and frustration on ethics committees. We just have to look at where the responsibility and the obligation lie and how those groups can be held accountable.
Thank you. Well, I think that there's going to be, hopefully, you'll have an opportunity to continue the discussion with our speakers, but we're going to end the session now, and I want to thank you for your attention and thank the speakers for their work and their presentations.